Hello everybody, my name is Dr. Sarah Davies. I'm a GP partner in Woodlands Medical Centre in Cardiff and I'm the National Clinical Lead for Diabetes in Primary Care. Over the next 10 to 15 minutes, I'm going to do a quick overview update on the brand new NICE Type 2 Diabetes NG28 guideline, which was updated just a couple of months ago. Here are my disclosures. So the previous iteration of the NICE guidance was 2022. This was the algorithm, if you remember it, for prescribing in type 2 diabetes. Not very easy on the eye, not the most colourful, but sort of started to move towards thinking beyond HbA1c. So the update was much awaited, 4 years in the making, and it has been really quite a significant change. So what are the main new messages in this NICE guidance? Well, really, I suppose the main movement is away from glucose centricity, so away from a focus on HbA1c alone to thinking about organ protection, but also taking a real individualized, risk stratified approach to care. So this is the new algorithm from NICE. Definitely a bit easier on the eye in terms of colour. Definitely still very complex looking. I totally get that if you do not share my enthusiasm for managing diabetes in primary care, this looks really complicated. I think it's worth mentioning at this stage that the main update has all been around the prescribing. All the advice around giving healthy living advice, talking about nutrition and exercise, considering remission of type 2 diabetes through weight loss, all of those remain a given, a really important part, of course, of the management of type 2 diabetes. The main updates are very much around the prescribing. So essentially what we've got here are 7 different treatment pathways, depending on the main comorbidity of the person with type 2 diabetes. So we've got one for people with no relevant comorbidities, so type 2 diabetes alone, fairly uncommon. We've got type 2 diabetes and obesity, probably one of the commonest treatment pathways that we'll use. People with type 2 diabetes and chronic kidney disease, those with early onset type 2 diabetes. This is a really interesting pathway to see NICE putting into their guidance. A real hot topic in diabetes actually, and it refers to people being diagnosed with type 2 diabetes under the age of 40, a rapidly rising group here in Wales and indeed beyond across the UK. They represent a really high risk group for early onset complications, premature mortality, early cardiovascular disease, etc., etc. So a specific pathway for them. People with type 2 diabetes and heart failure, those with ASCVD, which is atherosclerotic cardiovascular disease, which would be atherosclerosis in any vascular bed. So they've had a stroke, an MI, angina, peripheral arterial disease, and a final pathway for people with type 2 diabetes and frailty. Now, in the interest of only having 10 to 15 minutes, I'm not going to go through each pathway in detail. I'm just going to take you through the main learning points across the guidance. So in terms of key points, what NICE have really done is simplified the prescribing from a diagnosis of type 2 diabetes. So what they now say is that everybody, apart from only those with severe frailty, should be prescribed modified release metformin and an SGLT2 inhibitor as dual therapy from diagnosis. And if metformin is not tolerated, an SGLT2 inhibitor alone. And for most people, that will be dapagliflozin now because it's off patent and there are significant cost savings for the NHS. You'll notice they mentioned modified release metformin, which is interesting. The reason they've done that is because NICE say that in general experience, I'm sure many of you will agree, it's better tolerated, and indeed it's now no more expensive than standard release. There's no need to switch people, as if you've got people who are already happy on standard release metformin, that's fine, but for new starters, we can go straight for modified release. They also remind us that if anyone's got symptomatic hyperglycemia at any stage, so at diagnosis or further down the line, so someone with a really high A1C, osmotic symptoms, it may well be appropriate there to use rescue therapy first of all, having made sure the person is safe and doesn't need to be admitted, and this is definitely type 2 diabetes. We can use rescue therapy using a sulfonylurea or insulin to bring down that blood glucose first of all, before starting on metformin and SGLT2. Now, of course, lots of people will fall into multiple of these treatment pathways. They may have cardiovascular disease and CKD, or frailty and heart failure. So which one should we use in that scenario? Well, NICE, a little bit woolly on this perhaps, say that if a person has more than one comorbidity, we should make a shared decision with them about which comorbidity to prioritise when choosing medicines. And for me, actually, it's about choosing the pathway that will be most beneficial to that person sat in front of us. So some key points, first of all, around SGLT2 inhibitors in the NICE guidance. They're recommending this SGLT2 inhibitor use very broadly for everybody with type 2 diabetes from diagnosis, not necessarily for glycemic control at all, but for cardiovascular and renal protection. When NICE have looked back at the previous iteration of the guidance, which did recommend SGLT2 inhibitors for many, they found that actually there was still significant underuse and inequality of use as well. So you were less likely to receive one if you were female, older, of black ethnic origin, or from areas of higher deprivation. So essentially this guidance aims to simplify things for everybody, modified release metformin and an SGLT2 inhibitor. In terms of how to practically do that, NICE say we should introduce the medicines sequentially and not simultaneously. And they actually say that we should increase the metformin to maximum tolerated dose and then add the SGLT2. Although they do also say we should add the SGLT2 without delay to ensure that people do not remain on metformin alone for prolonged periods. My practical suggestion is to do it about 4 weeks. So we actually give both of the prescriptions at the conversation. We tell the patient to start taking the metformin, and then 4 weeks later they get a telephone call. Hi, how are you getting on with your metformin tablets? Fine, great, well done. Now start the next one, the one we talked about to protect your heart and kidneys. Do I always get people to maximum dose metformin before I start the SGLT2? To be honest, no. I'm keen to start getting that organ protection early on, but for many they will reach that maximum dose within that first 4 weeks or so. In terms of safety, of course, if we're using SGLT2 inhibitors for everybody, we have to think about safe use. And the main perhaps concern that we worry about is that of diabetic ketoacidosis. And NICE do make a specific recommendation to reduce that risk. They say we should assess whether the person may be at increased risk of DKA. For example, they've had one before, they are unwell. Of course, we wouldn't be using an SGLT2 inhibitor with anyone acutely unwell. They're at risk of volume depletion, or they're following a low carbohydrate or ketogenic diet. If we can address any of those modifiable risk factors, we should do so, or indeed delay an SGLT2 inhibitor if appropriate. I also suggest we should be cautious in people with a very high HbA1c. First of all, if someone's got an A1C above 100, they are theoretically at risk or higher risk of being pushed over into DKA, particularly if they do become volume depleted, for example. But also, they're less likely to tolerate the SGLT2 at a high A1C, more likely to get thrush and polyuria and so on. So if it's over 100, I tend to use something else to bring it down and then get the SGLT2 inhibitor in later on. We should, of course, ensure that we are giving and documenting that we've given clear sick day rules advice. And I've linked some resources here, one from Diabetes UK and one from Trend Diabetes, which are always an excellent source of up-to-date patient leaflets. What about GLP-1s? Perhaps the most awaited area of the NICE guidance was where they were going to put the GLP-1s. We knew that they were going to make them a little bit more available, and they have done that. So the guidance does allow earlier use of GLP-1 receptor agonists or indeed dual therapies such as tirzepatide for many people. Let's have a look at whom this applies to. So if someone has got type 2 diabetes and obesity, defined as a BMI of greater than 30, remembering we should adjust for ethnicity, we can start a GLP-1 or tirzepatide third line after that person has had at least 3 months on metformin and an SGLT2 inhibitor combination, and crucially, that their HbA1c is still above their individualized target. That's important. So those difficult conversations where perhaps people want to start these medications or want to increase doses, we are still doing that only when HbA1c is above individualized target. Now, for most people, that will be 53 millimoles per mole. If someone's younger, we should actually lower that target to 48 millimoles per mole, and then we can add in or increase doses. But if HbA1c is already 30 or 35 on previous medications, we can't be increasing doses of GLP-1 for those individuals for their type 2 diabetes. The other area where we're allowed to use GLP-1s earlier, however, and slightly differently from that, is in that high-risk group that I mentioned, those under the age of 40. And here, NICE say that we can actually use triple therapy, metformin, SGLT2, and a GLP-1 or tirzepatide without having to repeat the HbA1c, and indeed with no specific BMI criteria. They still say we should start one at a time. So if you're going to do this and the patient wants to do this from a diagnosis of type 2 diabetes in someone under 40, thinking about pregnancy safe medications first of all if relevant, I would suggest we could add every 4 weeks. So you could go metformin, 4 weeks later SGLT2, and then perhaps either 4 or 8 weeks later, seeing the patient to start them on a GLP-1 or tirzepatide. I'd then be repeating the A1C probably 3 months after that to see how we're doing. And as I say, in this group, we can aim for that low HbA1c of less than 48 millimoles per mole. Finally, and probably one of the biggest practice changes for me personally, is in people with known atherosclerotic cardiovascular disease. So if your patient has a history of atherosclerosis in any vascular bed, here we can use semaglutide, and they specifically mention semaglutide subcutaneous in the NICE guidance, in addition to other medications, for cardiovascular risk reduction. So here we're adding the GLP-1 regardless of HbA1c, regardless of BMI, because in clinical trials, and here we're thinking about the SUSTAIN 6 cardiovascular outcome trial, it reduced the chance of going on to have another cardiovascular event and improved or reduced rather mortality. They make a specific recommendation in people with atherosclerotic cardiovascular disease to use semaglutide. That is Ozempic up to the 1 milligram dose. They do not include tirzepatide in the recommendations here, really simply because the tirzepatide cardiovascular outcome trial was published a bit later on and was not in the NICE analysis. It has shown cardiovascular benefits in its cardiovascular outcome trial, arguably perhaps not as favourable as semaglutide. So NICE do make the specific recommendation of semaglutide, having looked at both clinical and cost effectiveness here. So if you've got somebody who's diagnosed with type 2 diabetes, who has a history of atherosclerosis, we could start on all 3 of these therapies, one at a time. But also if you've got a patient with type 2 diabetes who had a history of atherosclerosis who is not already on semaglutide or a GLP-1 or GIP receptor agonist, we can be adding that on for the cardiovascular risk reduction regardless of A1C or indeed BMI. This leads to a few safety concerns and some frequently asked questions, which I'll try to answer now before I finish. In terms of safety of GLP-1s, again, if we're using them more broadly, we need to think about safety, of course. So retinopathy is perhaps the one thing to really consider. If we start somebody on a GLP-1 with a high HbA1c and their HbA1c falls rapidly, there is a risk of worsening of retinopathy. So what we want to do is before we start a GLP-1, particularly if someone has got a high A1c, check their retinopathy is up to date. And if they haven't had screening recently and there's going to be a delay in waiting for it, you can consider using optician services, and opticians are happy to provide this photograph of the back of the eyes to make sure there's no pre-proliferative or proliferative disease. So long as that's not the case, we can start. If someone is under eye clinic already with diabetic eye disease and you're not sure, it's worth liaising with them and arranging early review if appropriate. And sometimes opticians will be keen, ophthalmologists rather, will be keen for us to still start because we know that actually better glycemic control is likely to reduce retinopathy over in the long term, but perhaps they'll want to see the patient a little bit more often. Finally, in terms of safety, pancreatitis risk. This is from the MHRA. We do need to be alert to the risk of acute pancreatitis. There are these rare reports of GLP-1s and potential association with necrotizing and fatal pancreatitis cases. So we should be advising patients when we start a GLP-1 or GIP that they should seek urgent medical attention if they develop symptoms or signs of pancreatitis. So abdominal pain radiating to the back, nausea, etc. If someone's got a history of pancreatitis, I would be very cautious in starting a GLP-1. NICE makes specific recommendations in terms of reviewing medications, and this is really useful because sometimes when you're reviewing someone with type 2 diabetes, should we carry on a medication? Should we stop it? Should we replace with something else? What they say is we should continue medications that have contributed to reaching glycemic and weight targets. So essentially, if something's working, carry it on. If someone's on an SGLT2 inhibitor for those cardiovascular and renal benefits, we should carry it on regardless of its effect on HbA1c. And usefully, they say that we should only stop GLP-1s if they're not helping people to reach glycemic targets. But if someone has cardiovascular disease or is under the age of 40, we can carry on regardless because of the additional risk reduction that it's giving those high risk groups. They do say specifically we should stop a GLP-1 if a person becomes underweight. So if they develop a BMI of less than 18.5, we should be stopping a GLP-1. To be honest, I'm often stopping well before they reach that kind of BMI. I get concerned about frailty and sarcopenia as BMI falls on these medications. And perhaps we'll come to that a little bit in these next couple of final slides. A couple of FAQs, because these are the questions I often get asked. First of all, can we use GLP-1s in people of lower BMIs? So NICE do not specify a BMI cutoff for GLP-1s anymore. For the majority of people, they will be of a higher BMI. For example, people with type 2 diabetes and obesity, and most people with type 2 diabetes and early onset type 2 diabetes tend to, and particularly with early onset, do tend to be living with more significant obesity. If someone's got atherosclerotic cardiovascular disease, or perhaps some people with type 2 diabetes just at a lower BMI, we can still use GLP-1s in this group. Now, the majority of the evidence base for GLP-1s is in a BMI of greater than 27. The expert opinion, and indeed the evidence that we have got, is they're likely safer at lower BMIs, but there is just less of a standard evidence in this area. And I do worry, as I say, about things like sarcopenia, muscle wasting, frailty, and so on. So for me, I'm going to take it on a case-by-case basis. You know, if I've got somebody with a BMI of 24, 25 with significant atherosclerotic cardiovascular disease, actually the benefits are likely to outweigh the risk, particularly if we're giving good advice around resistance exercise and so on. Should we stop a GLP-1 once someone's HbA1c is low? Definitely the commonest question I've been asked over the last year or so. Nice and clear here, which is really helpful. We should continue medications that have worked. So even if someone is on metformin, SGLT2, GLP-1, and their HbA1c's come down to 35 or 33, we should carry it on because it's working, so long as there's no hypo risk. You know, if they were on a sulfonylurea as well, I'd think about reducing the dose of that actually to negate any hypoglycemia risk. But there's no need to stop, because we know if we do stop the GLP-1, it is very likely that person's metabolic parameters will rise, they will regain weight as well, unless of course they want to stop and see if they can maintain. What I will always do, of course, is have a shared conversation with the patients. We should be ratifying medications as we always would. And if someone's on a high dose of a GLP-1, say they're on semaglutide 1 milligram or Mounjaro 10 milligrams, for example, I might try coming down on the dose and seeing if people maintain at a lower dose. That seems to make sense and is, of course, a sensible approach to reviewing medications. So how are we going to implement these guidelines effectively? And I'll leave you in your own time to look through those pathways and to see, what it's going to mean for your individual practice. It will, of course, take much time to implement significant changes like this to NICE guidance. And we're going to be doing that as we go along. So as patients come in for their annual type 2 diabetes reviews, we can then be thinking about that person, perhaps with the new NICE guidance at the back of our minds, and seeing whether we should be offering anything in addition for that person, and indeed when we're seeing people newly diagnosed as well. So it will take time. There are a couple of perhaps helpful starting quality improvement ideas you might want to think about in the meantime. So do a search for your patients with type 2 diabetes who are under the age of 40. It is not many people per practice. Are they well controlled? What's their HbA1c? When were they last seen? Are their care processes up to date? And in terms of their prescribing, are they on metformin, SGLT2, GLP-1? If not, perhaps it would be appropriate to think about an early review of this group to think about guideline-directed medical therapy for them, if appropriate, remembering, of course, about women at risk of pregnancy. And certainly the group with type 2 diabetes and atherosclerotic cardiovascular disease, again, an interesting group to review. And that search is on the All Wales Diabetes module, Audit Plus, via Informatica. You can see your list of patients with type 2 diabetes and cardiovascular disease. And again, you may want to consider an early review, particularly for adding in that semaglutide or GLP-1 option for the cardiovascular risk reduction element. Local health board pathways will take time to catch up with NICE guidance. I know this is a big change for everybody. A quick plug for the Primary Care Diabetes and Obesity Society. If you haven't looked at our website before, do have a little look. Free to access all of the education on there. There's a webinar we've recently done around the new NICE guidance, and some really nice algorithms and reading to do all about that if you want a bit more information. I am on the committee, a little declaration of interest. Thank you very much for listening, everybody, and I, of course, welcome your questions. Thanks.